Please let me know if you see them.
Yes, we can see them.
Okay. Right. So the topic I've chosen for this afternoon's rounds is the double burdens of morbidity and racial disparities as they apply to sickle cell disease. And the objectives we have for this afternoon is to provide some background information about sickle cell disease and explain why sickle cell disease is so common among people of Black descent. And then to outline the impact of systemic racism on this disease, on the experiences, and how social determinants of health really impact on disparities in outcomes. And we will reflect on some of the new developments in Ontario that are aimed at addressing these disparities. So sickle cell disease has been known for thousands of years. In fact, the earliest description we have of sickle cell disease came not too long ago from pre-dynastic Egyptian mummies. The DNA from a dental sample of one of such mummies revealed the sickle mutation. And this will be about 3,000 years BC. Also of note, a Ghanaian scholar, Professor Konutia Hulu, was able to trace in his own family 9 successive generations of people who manifested the telltale signs of sickle cell disease. And this would be around 1670 AD. But really, the first indication we had of sickle cell disease as a scientific publication was this first published case of sickle cell disease in 1910 by James Herrick, entitled Peculiar Elongation and Sickle-Shaped Red Blood Corpuscles in a Case of Severe Anemia. On the left is the notes of the intern who saw a 20-year-old dental student from Grenada who had come to the University of Chicago to train as a dentist. 3 months into his visit to Chicago to study dentistry, he fell ill, he became febrile, and he was seen by this intern who actually did microscopy of his blood smear and actually sort of traced this sickle-shaped red cells, which nobody had ever described before. So at this point, they had no idea what was causing this. They wondered whether it was the way the sample was handled, and they didn't know at all that this was an inherited condition. Later on, a few people reported that he had found the same sickle cells in people of African descent. But actually, sickle cell is one of the first diseases that was determined to be a molecular disease. Far back in 1949, Linus Pauling, who was later to become a Nobel laureate twice, actually demonstrated using this simple experiment that sickle cell disease must be a molecular disease. He did electrophoretic analysis of a normal patient and compared that with a patient with sickle cell anemia. But he could show that if he did the same thing on a sickle cell trait patient, he would see 2 peaks in the same location as the normal and abnormal, suggesting that the trait had both normal and abnormal. And he could recapitulate this by mixing a sample of normal with a sample with sickle cell anemia. This was one of the first established cases of where investigation had proved that a disease had a molecular basis. Remember, this was 1949. 7 years later, it was demonstrated that the difference between hemoglobin A and hemoglobin S was only 1 single amino acid. And this was done by Dr. Ingram in Cambridge using 2-dimensional chromatography and electrophoresis to show that it was only 1 amino acid difference. So sickle cell disease became the first molecular disease in humans for which the molecular basis at both the genetic and protein level was known. But it would take several years to understand that possibly there could have been multicentric origins of this disease, and this is based on restriction fragment-led polymorphisms of the beta globin cluster gene on chromosome 11. That if you look at patients with sickle cell disease, there were different polymorphisms: the Senegal, the Benin, the Bantu and Cameroon, and then the Indian haplotypes. And these haplotypes actually demonstrate some differences in their disease phenotype. For example, those of the Arab Indian phenotype tend to have high expression of fetal hemoglobin and tend to have a milder disease course compared to those with the Benin or the Cameroon or Bantu haplotype. But recently, whole genome sequencing data using phylogenetic network analysis is beginning to suggest that actually it may have been a unicentric origin, that is, only one origin, which may have occurred over 7,000 years ago, somewhere in the Green Sahara or West Central Africa. So where we have the Sahara Desert in this modern times will have been a forest area, and around 300 generations of it has resulted in sickle cell disease being predominant in places where malaria is present, because the heterozygous has an advantage in being able to resist malaria infection. So migration from these areas to East Africa, to the Bantu expansion, and then to India, and westwards to the Senegal area is the reason we have sickle cell disease in these particular epicenters of the world. Now we have both experimental and epidemiological evidence that actually the determinant of this sickle mutation distribution across the world is actually malaria. On top here, you have areas of the world where sickle cell disease is prevalent. So this is every single case that has been documented is mapped here. And the map below shows you the malaria endemicity in human history. So many, many years ago, you have malaria endemicity in all these areas of the world. And if you look at the map of Africa and India particularly, you can see how similar this map is to this one. You can see that south of the Zambezi River in Africa, you don't see much of sickle cell disease at all. And you see it in sub-Saharan Africa, in India, in the Arabian Peninsula, and also in certain parts of Southern Europe. And then migrations from here to the Americas from the slave trade is the reason why sickle cell disease is now prevalent in Brazil, in the United States, and now really all over the world because of other migrations, including economic migrations. So we know that it is the survival advantage that is provided by heterozygosity of the sickle gene that determines the distribution of the gene. And so now, when we look at the global health burden of sickle cell disease, you can see that sub-Saharan Africa shoulders the heaviest burden. And then you have places like the Arabian Peninsula, India, Brazil, and parts of North America. And now Canada, increasingly, with recent migrations from these parts of the world, sickle cell disease is beginning to become more frequent than it was before. This disease is a multi-systemic disease. And I hope that by the end of this talk, when you encounter a patient with sickle cell disease, I hope that you will express some degree of empathy and compassion, because this is really an endothelial disease. The single most important event with this disease is hemoglobin S polymerization. And this happens when the hemoglobin gives off the oxygen. In the deoxygenated state, hemoglobin S polymerizes and forms polymers. Acidosis makes it worse, and increased hemoglobin S concentration makes it worse. But this single event leads to a cascade of events. First, the red cell gets very rigid. it becomes adherent to the endothelium, and then it gets broken down much quickly. So there's hemolysis. With the rigidity and the red cell adhesion, there's endothelial activation and endothelial damage, activation of the coagulation pathway and the inflammatory pathway. And all this together with the endothelial activation really gives rise to vaso-occlusion, which is one of the hallmark presentations of this disease. The hemolysis gives rise to chronic anemia, leading to tissue hypoxia. And the combination of tissue hypoxia, endothelial inflammation, vaso-occlusion leads to multiple organ damage and early death. But probably one of the most important symptoms of this disease is excruciating bone pain as a result of vaso-occlusion. And by the way, the pain of sickle cell disease is now determined to be second probably only to terminal cancer pain, much worse than labor pain. And so in acute vaso-occlusive crisis, these patients are really facing excruciating pain of the highest order. As a result of the endothelial damage, really no organ of the body is spared of its impact of sickle cell disease, right from the brain, actually, which is one of the most vulnerable organs because of its dependence on oxygen. And endothelial damage to the blood vessels makes stroke a common manifestation of sickle cell disease. So even if they don't have overt stroke, they will have silent stroke, which can affect neurocognitive development. So the lungs, the heart, the spleen, the liver, the organs of the body, the spleen, the gallbladder, the bones, and the skin, every aspect can be affected by sickle cell disease. So we should view sickle cell disease not as simply as a blood disorder, but rather as a multi-systemic inflammatory disease, which is associated with end organ damage and early death if it's not appropriately treated. This is showing you silent cerebral infarcts, and this is so troubling. It means that in sickle cell patients, even if they don't manifest overt stroke, they have evidence of silent cerebral infarcts that can affect neurocognitive damage. And what is worrying here is that it extends right from early childhood and right into adulthood with increasing prevalence of silent cerebral infarcts. So if you meet a sickle cell patient who cannot remember the appointments, who cannot keep to instructions, remember that there could be silent cerebral infarcts affecting this patient and therefore impacting on their neurocognitive executive function. But there are social determinants of health, and I don't need to really educate you about how these social determinants affect health disparities. Access to good education, be able to understand health-related information, opportunities for good income, good employment, poor housing, food insecurity, all these could impact on disparities in accessing health services, leading to low and poor health outcomes. So even when the health services are available, the lack of transportation, the lack of employment, inadequate housing and food insecurity could impact on the family's ability to access the health resources. Therefore, we see a lot of no-shows, a lot of non-attendance to investigations, purely because these challenges are faced by patients and families every day. They are the people of the lowest socioeconomic status based on SickKids' own data. There's lack of cultural specificity in the health education they receive. So the health education they receive is not well understood, it's not well processed. There's underrepresentation of Black healthcare professionals who will understand the culture and be able to present the information in a way they can understand. In fact, there is evidence based on a lot of work that has been done, mainly in the United States, that where there is racial concordance between patients and the care providers, you have better outcomes because there's better understanding of the cultural specificity of health information. Therefore, people living with sickle cell disease have a lot of challenges. We think that more than 6,000 Canadians live with sickle cell disease. And for most of these people, they face health-related challenges, a lot of misconceptions. There's a lot of stigma even within these cultures about sickle cell disease, so much so that some families will not share the diagnosis even with close family. There are barriers, systemic racism and healthcare inequities that all impact on the lives of patients and their caregivers. The symptoms of sickle cell disease are burdensome. Overall, although bone pain is what we are familiar with, actually the most distressing symptom that sickle cell patients have really volunteered is fatigue and tiredness because of the chronic anemia. Their basic hemoglobin will be half those of normal children their age, and their inability to fit into the classes in which they are at school and be able to participate in school exercises, and the tiredness, the chronic tiredness with adults, the fatigue is one of the things that really distresses them most. Headaches are common, and low mood and depression is very common among patients with sickle cell disease. They have poor sleep, and they worry and are anxious that they are going to die early. In fact, in our clinic, many of our patients have been told by their classmates that they are not going to live long. And so they worry, they have anxiety, and they have chronic symptoms. And these symptoms impact on their education and their career opportunities. School attendance is not consistent. Work attendance is not very well maintained. It's difficult for them to keep employment. Their earning potential is impacted. And all this impacts on their overall well-being and their mental health. The incidence of mental health issues among sickle cell patients is one of the highest in people suffering from chronic diseases. As I said to you, in 1948-49, we knew that sickle cell disease was a molecular disease. In 1956, Vernon Ingram demonstrated the single point mutation that is associated with sickle cell disease. However, for decades, there was no progress in treatment for sickle cell disease. And this is data showing you the legacy of excellence in sickle cell disease, but probably one could say the legacy of lack of excellence in sickle cell disease, because until the 1970s, virtually nothing happened with sickle cell disease, although we knew the molecular basis for it. I will leave you to really hazard a guess why that is so. And I would say that it's because this was predominantly found in African Americans. It was not an exciting area to research. There was no dedicated programs for people with sickle cell disease in the United States until the National Sickle Cell Act was passed during the tenure of President Nixon. So in the sickle cell arena, although President Nixon is often vilified for all the things that happened with Watergate, the one single act of passing the National Sickle Cell Act brought great transformation to sickle cell disease in the United States, because they got established sickle cell specific centers that were funded to do basic research and clinical research, translational research in sickle cell disease. And that also led to the penicillin prophylaxis trial that gave the impetus for newborn screening, early trials on hydroxyurea therapy, the only disease-modifying therapy that is taken orally and daily, and that can impact the disease, and then chronic blood transfusion, which was found to be able to prevent complications like stroke. So it took this act passed in Parliament, in Congress, to really change the scene for sickle cell disease. Now, let me focus a bit on hydroxyurea therapy. So hydroxyurea therapy is really the only consistent disease-modifying treatment that has been shown to have efficacy and effectiveness in people with sickle cell disease. There have been over 30 years of research on sickle cell disease, right from proof of principle studies in 1984 up to this current moment when sickle cell hydroxyurea studies have now been done in sub-Saharan Africa. And I show this slide to suggest that the way hydroxyurea is presented to families with sickle cell doesn't really pay respect to the decades of research on this medication and its impact on sickle cell disease. I'm showing you two double-blind placebo-controlled trials, the MSH in adults, the baby hug in toddlers and infants from 9 months of age to about 3 years of age. And you're looking at HU and placebo for baby hug, HU and placebo for the multi-center study on hydroxyurea. And when you look at the patients, they were well balanced. Pain was reduced in both adults and children significantly. Acute chest syndrome was reduced. Dactylitis was significantly reduced in the children. Hospitalization was much less, and transfusion requirements much less. These are double-blind placebo-controlled trials. So from these, one can deduce that hydroxyurea is the treatment for sickle cell anemia. It's not a question of whether the parent will have to decide or whether the parent will have to think for themselves whether hydroxyurea is indicated. The power of this evidence suggests that it is the treatment, and the recommendation should be, this is the treatment for it, no less than inhaled corticosteroids is the treatment if you have chronic asthma. The dose that you take is important. The top and the bottom are two patients. Patient number 1, this is pre-treatment of hydroxyurea. This is the commencement of the dose. And you can see on the peripheral smear that the red cells are much redder. You have fewer elongated sickle cells. But this is not optimal. You need to optimize it to maximum tolerable dose, because at maximum tolerable dose, you have higher hemoglobin, you have less irreversibly sickle cells. It's the same for patient 1 and patient 2. Therefore, starting the treatment is not sufficient. One has to follow up the patient and make sure that treatment is optimized, because it is at the optimized dose that they derive the fullest benefit from the medication. I've seen so many patients on hydroxyurea who are not optimized, who are not gaining optimal benefit from the drug, because monitoring and evaluation to ensure that they have reached maximum tolerable dose has not been done. So if HU therapy is clinically efficacious with strong evidence from double-blind placebo trials, if it's minimally harmful and has easy way of taking it just once a day by oral route, and it's relatively affordable, probably one of the cheapest disease-modifying treatments you could find for any chronic disease, why then are there a significant number of patients with sickle cell anemia who are not on hydroxyurea therapy? And why do some patients fail to adhere to the therapy? And I think from what I've said previously, the way it is presented to many of them is as though they have the choice not to go on hydroxyurea. I wouldn't do that when a child has chronic asthma or has diabetes. With regard to treating the diabetes, the treatment for this disease is hydroxyurea therapy, and the presentation has to be in that light, because double-blind placebo-controlled trial has shown efficacy as far back as the 1990s. It's not new evidence, it is very old evidence. So we should be doing everything possible to promote treatment uptake and to promote adherence to therapy. If we do not do that, we are reinforcing disparities in outcomes and denying children and adults disease-modifying treatment that can improve their quality of life. So how do we promote uptake? Healthcare professionals need to provide the message that hydroxyurea is the standard treatment for sickle cell anemia based on all the evidence. And this should be presented in a culturally sensitive way with patience and with empathy, understanding the outcomes of this disease if it is not treated in a disease-modifying fashion. Awareness of the implicit biases that influence our conversations with family, how we present it, how we respond to their questions, is something that will help us to be able to promote hydroxyurea uptake. We need to educate families using culturally appropriate medium and language that they can understand, simple, with diagrams, with evidence, and with patience. And we have to combat their fears about cancer and infertility, which often is a barrier why they don't use hydroxyurea therapy. And I think rather than wait for them to ask questions, we should present that evidence that cancer and infertility after decades of using hydroxyurea is not proven to be a barrier to taking the medicine. We also ought to make cost effectiveness argument to the healthcare system that is far cheaper and far more effective to use hydroxyurea therapy than to manage crisis as inpatients or in the emergency department. It saves money, it improves quality of life. And so the entire healthcare system needs to work hard to promote uptake of hydroxyurea treatment. This brings me to the quality standards that Ontario Health has established. Ontario Health has done quality standards for nearly 40 conditions, and sickle cell disease happens to be the latest. It is the only quality standard for which a co-chair of the advisory group was a patient with a lived experience. And it is the only quality standard for which one of them was racism and anti-Black racism. It's not something you will expect to be a quality standard. But when we discussed this with families and patients and with care providers, it was clear that this is the number one barrier to maintaining high quality of care for people with sickle cell disease. People with sickle cell disease need to be treated with respect, dignity, and compassion to work to establish trust with them and to really recognize that compassionate, trauma-informed, and respect for people for their racial and ethnic cultural backgrounds is critical in being able to offer them the best services and also to improve their quality of care. So we need to advocate for people with sickle cell disease and treat them with the compassion and the empathy that they need. Comprehensive care and assessment. Every sickle cell patient must have comprehensive assessment at least annually through an interprofessional care team that is dedicated in a sickle cell center. And the plans that are developed should be individualized, should be person-centered, and should be associated with a monitoring plan to ensure that they adhere to this monitoring and this assessment and care. The occlusive acute pain episodes need to be managed promptly. Like I said, the pain is excruciating, and therefore we need to address pain soon after they reach the healthcare environment. Within 30 minutes of triage or within 60 minutes of presentation, we think the first dose of analgesia needs to be provided to relieve their pain, which significantly impacts on their quality of life. They may present with life-threatening complications, including stroke, acute chest syndrome, acute spinal sequestration. All these are life-threatening complications, even if they do not look very much unwell the first time they are seen. They can deteriorate so quickly before your very eyes because they have no residual capacity to deal with hypoxia and to deal with organ inflammation and damage because of their chronic illness. Chronic complications are common in sickle cell disease, from the brain to the heart to the lungs to the kidneys. All these complications need to be looked at, eye examination, visit to the orthopedic surgeon. Referral to healthcare professional with expertise in chronic pain because of the multiple use of opioids and the regular use of other analgesics. When they develop chronic pain, they can be a challenge to manage. And we need people with expertise in chronic pain management to help them through this phase of their lives. Social assessment and information and support is absolutely crucial. We've talked about the social determinants. We've talked about the economic determinants, mental health, depression, and anxiety. These are all compounding to make support for this patient population absolutely crucial for them to be able to deal with their disease. And then when they transition from youth to adulthood, there needs to be continuity of care. They need a process that ensures seamless transition from pediatric to adult care. I'm proud to say that in SickKids, we've been able to establish an excellent program with the use of a transition navigator that is cross-appointed between Toronto General and Hospital for Sick Children. This model needs to be replicated across Canada because it ensures that their care from pediatric to adult care becomes seamless and is maintained to ensure that they do better. In fact, in pediatrics, we have sickle cell disease at its best. It is in adulthood that end organ damage is very evident. And so we should make sure that they should have continuing care as adults when they leave pediatric care. In summary, I would like to say that sickle cell disease is a chronic inflammatory disease. Sorry, I think it's not project. There's a problem here. But what I wanted to say here is that it's a chronic inflammatory disease that requires disease modifying approach. People living with sickle cell disease are having challenges because of their social and economic determinants, where they live, what kind of job they do, or their parents do, what kind of education they have, their income, their food security. These are all challenges that they face every day, challenges that we take for granted. And because of this double burden of morbidity and social determinants, these patients require a lot of compassion, a lot of empathy, a lot of support for us to be able to give them the care that they need. Ontario Health has developed quality standards, and I believe this will go a long way to help address some of these disparities. The health system needs to recognize that because of systemic racism and inequities in the system, access to using the resources that are available can be challenging for these families. And it is for this reason that we all need to work together in a concerted effort to go a further mile to address the needs of this patient population and use disease-modifying therapies universally to address their needs in terms of disease and organ damage. Thank you very much. We are now going to see some videos of lived patients' experience with sickle cell disease.
Thank you, Dr. Odame. We're just waiting for the videos, is that correct?
Well, I think we can, if it's not ready, we can skip that for now and go into the discussion phase and questions. We've intentionally left a lot of time for discussion because we think that this is where we can have good interaction, exchange ideas, in the hope that what we come out with will be some blueprints of how we can be guided when we face patients and families that live with this disease. Just like I've said, they are facing double burdens. The burdens they bear are too heavy. And those of us who come around them should be doing everything possible to make that burden lighter for them. And the way we do that is compassion, empathy, patience, understanding, being culturally sensitive, and doing everything we ought to do to help them. I will give a good example of an encounter I had with a patient. So I had a patient who for many years, the family were resistant against using hydroxyurea therapy, although this boy was frequently symptomatic and was a frequent user of the emergency department. They were fearful because hydroxyurea is classified as an anti-cancer drug. But I never gave up on them. Every time they came to clinic, I will revisit the issue. The parents then told me that they relented for one simple reason. They relented because they said, why doesn't he give up? And they thought the father was so persistent and so insistent that this is the best for the child. They thought, let's give it a try. And when this boy was transitioning, the parents told me this story. I had no idea. But they thanked me profusely that I did not give up. I was patient with them because they did realize that they should have started the medication much earlier. It is this degree of persistence that is based on compassion that is needed to sometimes move these families from being distrustful of the system to a position of trust. A good example of how compassion, empathy, care, persistence really pays off because eventually trust is established and the child is the beneficiary of that decision. So Priscilla, I'll leave it to you to coordinate the discussion.
Absolutely. So at this time, I would like to invite anyone who has questions for Dr. Odame to please raise their virtual hands. You're also welcome to leave your questions in the chat, and I'll be sure to bring them to his attention for conversation. Now, I see someone has put a question in the chat. Thank you, Doris. It says here, many thanks for the great talk. Do you know how the access to HU is in endemic countries? Is it provided as part of MOH protocols?
That's a great question. Actually, I spend most of my time these days trying to make hydroxyurea. Actually, my goal is that hydroxyurea should be freely accessible to all patients living with sickle cell disease in the world. Now, this molecule was synthesized in 1869, ladies and gentlemen, 1869. It's such an old molecule. It is so cheap. It can be easily produced around the world and distributed to all patients who need it, even without cost. The world can do it. We just lack the will and the motivation to do it. We're trying to get the World Health Organization, UN organizations, the World Bank. We're trying to get multinational partners to come into the fray to make this medicine easily accessible to all patients who will benefit from it.
Thanks for the great question, Doris, and for your response, Dr. Odame. I see that Stanley has his hand raised. Stanley, would you like to unmute yourself?
Thanks very much, Priscilla. And Isaac, great talk, not surprising. Isaac, do you want to say a couple of words about the challenges you faced in establishing a newborn screening program in Ghana? If anyone could do it, it would be you. You come from Ghana originally, and you've been such a huge proponent for sickle cell disease identification and treatment. You were the person who started the sickle cell network, yet my understanding is that you had major challenges in a country with a huge number of children either at risk of or having sickle cell disease. Can you say a few words about the challenges you faced in starting the newborn screening program in Ghana?
Yes, perhaps to begin answering that question, let me start with the challenges, even with having newborn screening done in Canada. So Canada was nearly 15 years behind the United States in doing newborn screening for sickle cell disease. Not because it was difficult, not because it was challenging, because we already have universal newborn screening, and all we needed to do was add an extra menu to the test. But I tell you, it took a lot of effort, a lot of persuading, a lot of making noise to be able to get. Ontario was the first to have universal screening for sickle cell disease in 2007. And I'm glad to say Quebec, British Columbia, Alberta, Nova Scotia, and others have joined because the evidence is so compelling. The problem with sickle cell disease is that when the child is born, the child is perfectly healthy because at birth, fetal hemoglobin makes up about 80 to 90% of the blood. The onset of sickle cell disease comes later. And so in many parts of Africa, when you do newborn screening and you're telling them that they have sickle cell disease, it's hard for them to believe. And even here in Ontario, many parents have difficulty accepting the diagnosis. In Ghana and in Africa, newborn screening as a system does not exist. It's something we've taken for granted in these parts of the world because it began with screening for phenylketonuria, congenital hypothyroidism. Even mothers deliver their babies, they are not even aware that their babies are being tested for nearly 28 disorders that they have no idea of. It's a system that exists. So when sickle cell disease was being added to the menu, it was a straightforward addition at the center where all blood samples are collected. Imagine going to Ghana where there's no newborn screening existent at all. So having them to establish a system where every child that is born is tested is a real challenge. And as a result, we are having to use innovative approaches by using some point of care tools linked to immunization. So one of the projects I'm doing in Ghana is actually taking advantage of the success of vaccination programs. In sub-Saharan Africa, regardless of where the child is born, whether at home or in a birthing institutions, virtually all of them receive primary immunization, something that has taken decades to perfect, even in low-resource countries. So we think we can link sickle cell screening to vaccinations, and that is beginning to prove very effective because you can get them there during vaccination and right at the point of care, determine who is a trait and who has got sickle cell disease and who needs counseling and intervention. So Stan, the conclusion that I've drawn with countries like Ghana, that if we are going to wait for universal newborn screening to become a system, it will be for many children a little too late. And so we are now thinking of how we can integrate sickle cell screening using point of care tools to immunization programs, which are already existent and have taken decades to establish.
Thank you, Isaac.
Thank you, Stanley, for a great question and a great conversation, Dr. Odame. I see that we have another question in the chat from Dr. Smile here. It says, great talk, Dr. Odame. Can you speak to the future of CRISPR gene editing in sickle cell treatment in pediatrics and adolescent clients?
Yes, I think that is a piece of good news that I can give to families with sickle cell disease, that sickle cell disease is a curable disease, not only through allogeneic bone marrow transplant, which only can be offered mainly to those who are fortunate to have another sibling who is HLA matched and who doesn't have sickle cell disease. But in this era of gene therapy, this is becoming very possible. So currently, some patients here in SickKids are participating in clinical trials of using CRISPR modification of their own hematopoietic stem cells to induce fetal hemoglobin production at levels that cure the disease. We will soon see by the end of this year, FDA approval of the first CRISPR therapy, curative therapy for sickle cell disease. That said, if you look at the current protocols, they are so expensive to be able to deliver. You have to collect the stem cells from the patient, send them to a manufacturing lab or a manufacturing site where the gene editing is going to be done. And then the stem cells will have to be returned to the patient who has been myeloablated by giving ablative doses of chemotherapy and then infuse the stem cells. This will work okay in a country like Canada because we have the resources to be able to do that, but it would be unthinkable to do it in a place like Sub-Saharan Africa. So now the race is really to find an in vivo gene therapy approach, whereby all you have to do is to mobilize the patient's own stem cells, inject the gene product, the gene modification CRISPR product as an IV infusion, and hope that the modified cells will home down to the bone marrow and be able to reconstitute a healthy hematopoietic cells that cure the disease. It's been proven now lately in a recent publication that this is experimentally feasible. And one is using even a better technique than the standardized CRISPR technique, using base editing approaches in combination with adenovectors, which are really very versatile and amenable to producing at large quantities at low cost. So now there's an adenovector base editing tool that has proven feasible in correcting sickle cell disease in sickle mouse models. The Gates Foundation, the NIH, Novartis are in an alliance with a race to find an in vivo gene cure that will be deliverable in low resource settings. So that is the hope for the future.
Thank you, Dr. Odame and Dr. Smile, for your question. I see we have a hand raised. Harpreet, would you like to unmute yourself?
Yes, thank you, Priscilla, and thank you, Dr. Odame, for a very, very enlightening and I think very comprehensive conversation and presentation from start to finish around the origins of sickle cell disease and just some of the continued disparities and challenges that are faced by children and families that are living with that experience of sickle cell disease. So in my role as program manager of patient family experience, I'm always very interested in the experiences that the children and families have. And you've spoken a little bit about, the need to be compassionate, sensitive, patient, and you've given an example about what that patience could look like in a clinical interaction. I'm wondering if you have any other insights from the conversations that you've had with various families about other supports that could have been provided to help families navigate the healthcare system, but also overcome some of those challenges, right, around the social determinants of health and just get better quality of care?
Yes, I'll give you a good example. So don't forget that many of these families are immigrants to the country. They often have difficulty understanding the healthcare system. They have even difficulty understanding the language, although they may not in all your explanation. I recall that, and even sometimes it's a cultural barrier. So I recall when I arrived at SickKids, and my colleagues in the Sickle Cell program will remember this, there was a family of Ghanaian origin that had been adamant that they were not going to use hydroxyurea therapy, although it was clearly evident that the child needed it. And so soon after my arrival, my team said, "Oh, Isaac, they come from Ghana. Why don't you talk to them?" And I will tell you that it took only 5 minutes. And when I returned to my colleagues, they said, what happened there? And all it was, as soon as they saw me and they saw my name, they knew that they were in a safe environment. And they knew that whatever I was going to tell them as a fellow Ghanaian is going to be the right thing. So all I said, you know the drug they've been recommending to you, I strongly recommend it. In fact, there are people in Ghana who are using that medicine today. And that was enough. So sometimes we need to be culturally sensitive and go the extra mile to create that environment of trust. Don't forget also that we have historical evidence of people of African descent that have been taken through some unethical experimental procedures that you will not consider as justifiable. And so in that kind of context, their trust in the system is questionable, and then they do not understand the principles that are being expressed. A second point I will make is that sometimes we are biased in our perception of their ability to understand what we are talking about. I've learned that actually they can understand the meaning of double-blind placebo trial. And the reason why one should explain that to them is that it helps them understand that biases have been removed in that study through a double-blind procedure. And if you can simply explain that to them, it helps them realize that what is being presented to me is not something that is experimental, which they know SickKids does a lot of. We do a lot of research, but rather something that has been tested over time using the gold standard of tests. And one statement I make is that if I didn't tell them about hydroxyurea, it would be tantamount to malpractice, any less than a woman with breast cancer is treated on a 20-year-old protocol when new protocols are showing far better outcomes. That oncologist will have malpractice. And I tell the parents, if I didn't do what I'm doing, that is the level of malpractice that you'll be talking about. And it gives them a sense that you are so confident of the evidence that it is so overwhelming that not talking about it is actually malpractice. So every pediatrician worth his or her salt who meets a patient with sickle cell anemia and doesn't talk about hydroxyurea therapy has failed that patient.
Thank you for posing that question, Harpreet. It was a really good one. I realize we only have a minute left, but there is one last question I'd like to get to in the chat before we part ways. The question for you, Dr. Odame, is you mentioned the impact of race concordant care. I wonder if you see this as part of the solution to effective care for this population, or evidence of opportunity for growth and learning on the part of others, or both?
Yes, indeed. And I think this has been realized in all aspects of medicine. And I'm so happy that the University of Toronto Faculty of Medicine has taken measures to increase the number of ethnic minorities that are enrolled into medical school. Because the care providers, the healthcare professionals must look like their community. And I think in areas where there is concordance and understanding and cultural sensitivity, we know that for chronic diseases, you get better outcomes. And so one has to be intentional in making sure that the diversity that we see in the community is reflected also in the healthcare professional, interprofessional community as well. Because with that, we'll have a more enriched, culturally enriched environment. I mean, I recall that there are patients in other departments who are having difficulty understanding what they are being told. And I get asked, oh, there's a Ghanaian with this disorder. We're trying to communicate with them. Can you help out? I mean, I think those kind of situations are opportunities for us to bridge those gaps. And now that we have a lot of interpreters, services, we have people who can make it culturally sensitive to them. I think we should utilize these opportunities. And all around Canada, I'm happy to know that most medical schools are now thinking of how they can increase the numbers of intake of people from ethnic minorities, racial minorities, to reflect their percentages in the population.
Well, thank you again, Dr. Odame, for joining our event today. We certainly appreciate your outstanding presentation that speaks to, the double burdens of morbidity and racial disparities related to sickle cell disease. It was absolutely fantastic to have you. I'd like to wish everyone a wonderful rest of the day, and we look forward to seeing you at our next event. Bye now.
Thank you, everyone.